let us go ahead and get started here with the presentation proper. Today's topic is using hospital outcome data. And I am, from what I understand, Josh, our EMS Data Consultant, I believe you have proper introductions for your co-presenters. So I'm just going to hand it over to you to go ahead and get started.
Okay, that sounds good. Chris, just so you know, I keep getting a pop-up saying that you're requesting remote control of my screen.
Oh,
It might be someone trying to fiddle.
There's someone in the meeting right now we need to remove. So if you could just hang on one second, Josh.
thank you,
Yeah,
Ben.
okay. All right. Well, we'll
We'll
see
take
if we
care of
can
that.
continue
You
with
go ahead
that.
and get
Okay.
started.
I think we're looking good now. Uh, Hello, everyone, and thanks for joining this NEMSIS TAC public webinar on using hospital outcome data. There's been a lot of talk recently about EMS getting hospital outcome data for the patients they take to hospitals. And what we really want to talk about today is, okay, if you get that data, what do you do with it? How is it useful to EMS? And what's the value of having it? What can it do for you? And so I'm joined today um, by Michael Wells and Jason Oko. So to introduce myself, I'm a NEMSIS TAC consultant. One of my contracts is with the NEMSIS TAC. I work with EMS data in general. And one of my projects with the NEMSIS TAC is focusing on improving interoperability between EMS and the rest of healthcare, getting that data flowing in all directions. Michael Wells is with us from Montgomery County Hospital District EMS in Texas. Say hi, Michael. And Jason Oko is with us from the Maine office of EMS on the opposite side of the country from me. So I think we've got it covered between Oregon, Texas, and Maine. So they'll be doing the bulk of the presentations today, sharing some things that they've been doing. I have a little bit of kind of background info that I'd like to share with you. First, want to just illustrate as we talk about interoperability between EMS and the rest of healthcare. These are kind of, if you boil it down, these are kind of the main, I guess, steps or points at which interoperability can happen. One is when EMS responds to a 911 call or any call for a patient, and they might access that patient's medical history from a health information exchange of some kind. Second is when they take a patient to a facility like a hospital to share information about what's happening on that EMS call with the hospital staff so they can be prepared to receive that patient. And even for later things like trauma registries, it's helpful to have that information from EMS. And then this piece where after the patient has gone to the hospital, getting hospital outcomes back to the EMS agencies so that they can evaluate the service and care that they provided and can improve that care over time. So as we look at hospital outcome data, last year, 2023 and 2024, I chaired an EMS interoperability task force. We had a bunch of people participating, including several of you. And one of the topics that we looked at in that task force was what information from the hospital is useful for EMS to have. There's lots of information available. It can be kind of a deluge of information, but what is it that's really helpful to EMS? And these are kind of the key things that we saw, on top of patient demographics and identifiers for the actual hospital encounter. These were the things that we were talking about that would be important for EMS to know. Dates and times, diagnoses, procedures, medications, disposition, vitals, length of stay, but then some things that are not necessarily covered in NEMSIS, but are really helpful to EMS. The treatment plan, patient movement within the hospital, any discharge instructions, prescriptions, referrals, risk scores. So those were the things we came up with. I've got a QR code here and a link, and Lori will put that in the chat as well, to the page in a wiki site where we documented these pieces of information that we thought would be helpful for EMS to get from hospitals. Okay, so back to this diagram that I was sharing. There's an additional piece that I want to highlight, and that is after EMS has gotten the hospital outcome data, the opportunity to send that information inserted into their patient care report to the state, and then for the state to send that information onto the national EMS database. So that the data that gets to the state and the national database would not only be what EMS did on their patient care report, but also include the hospital outcomes that EMS received from the hospital. Now, when we look at how many patient care reports in the national database have hospital outcomes, the numbers have been very low. I've shared these for several years. They are increasing, but it's very gradual. We made incremental progress in 2024 to be just over 3% of patients that were taken to a hospital had hospital outcomes recorded on them in the national database. So, I had to adjust the scale over here on the left side to a 10% max for these bars to even be visible. That's how small it is. Now, 2024, it is the first year that the national database had over 1 million patient care reports that had hospital outcomes, but it's still just such a very small percentage. And when we look at it broken down by agency, we see that the vast majority of agencies are not sending any outcome data to the national database. Now, some of them may be getting it, but not sending it. So we have just a few agencies across the country that are actually getting and sending hospital outcome data up through the chain. If we break it down by vendor, this one outlier up here is a product that had 200 records in the national database last year. If we ignore that one, we see that the vast majority of the vendors, we're seeing zero outcome data on their records in the national database. And when we look at it by state, the outlier here is the Northern Mariana Islands, and we think that they're doing some kind of manual process to get the hospital outcomes. If we set that one aside, then we see that a lot of states are also at zero, but we do have a few that are at least getting something across their state. And interestingly, this second dot here, the first one in line after the Northern Mariana Islands is Maine. And I'll show you in a second why we're going to have Maine, or a little later, why we're going to have Jason from Maine sharing some information with us. So it's slow going. We know that there are agencies out there that are getting outcome data and it's just not making it to the national database. We consider that to be the low-hanging fruit in the national database. But we also know a ton of agencies just aren't getting it at all. And what we'd like to do today is say, okay, here's why this outcome data would be important. Here's what it can do for your agency. So I want to explain why I chose Michael, and then I'll hand it off to him, and then I'll explain why I chose Jason, and we'll hand it off to him. The two of them will share the bulk of this meeting today. So this is why I chose Michael. When I looked in the National EMS database and I broke it down by agency, I noticed that Montgomery County Hospital District EMS in Texas was getting some outcome data back in 2021 and sending it to the national database. Then I saw a drop in 2022, and then I saw it come back in 23 and increase further in 24. This told me that they were doing something, and that when something broke, they figured out that it broke and they were able to fix it. And that was very interesting to me. So I chose Michael because it's not just that he can say he's getting outcome data from hospitals. It's that he can demonstrate it because his agency is actually sharing it to the state and it's getting to the national database. So I have that definitive proof that his agency is actually getting hospital outcome data. And I want to help more agencies to get that process end to end, get the hospital data, but also get it all the way to the national database. So with that, I'm going to turn it over to Michael, and he's going to share what they've done, and especially, as I've been talking about, what good has it been for them? What has it done for their agency and their patients and their hospitals? So Michael, I'll turn it over to you now.
Awesome. Thank you so much, Josh. That was a wonderful introduction. So yeah, we have really made a focus to include hospital outcome data in our overall clinical model. I'm going to go through some of the practical applications from an agency level here today and how we work with our hospital partners to achieve that. So in case you're not familiar with MCHD, we're a hospital district without a hospital. We provide EMS and indigent care for Montgomery County, Texas. We're the county immediately north of Houston. Just some numbers from 2024, we had about 75,000 incidents. Our dispatch center took about 120,000 phone calls, and just for fun, we did about 48,012 lead EKGs. One of the kind of key fundamental principles to everything we do with healthcare technology at MCHD is we really focus on getting the right information to the right people at the right time to improve our clinical care. Whether that is getting our PCR to the hospital so that they have the full EMS record to impact their decision making, or getting those outcomes back to our medical or our clinical leadership to be able to improve quality of care, or just getting patient history information to our medics' hands in the field at the time of treatment. All of those things are fundamental to us trying to use the technology to get all of this information to the right people at the right time. Today, we're going to focus specifically on outcome data. I could talk hours at end about all of the different things that our PCR system connects to. But really, I want to focus kind of on 5 key areas of practical application. Billing and insurance data that you get back, the crew feedback, continuous quality improvement process, protocol development kind of goes hand in hand with that. And then, of course, research, which is near and dear to my heart, especially with the national NEMSIS data set. So one of the things that one of the financial things that we're able to use to justify the cost for having these direct hospital connections is that it gets us the billing and insurance information. Our billing department, their biggest challenge isn't necessarily getting payers to pay, it's finding the payers that the patient already has. So we've got a few technology tricks in our hat when it goes into the billing system, but ultimately we get a lot of our insurance and payer information directly from the hospitals through this automated outcome exchange. Insurance reimbursements becoming more complex. They're looking for just about anything to deny a claim. So when your crew member mistypes one letter in that insurance ID number, automatic denial because they don't match. Well, we can use that automated outcome data that is perfect and doesn't require a human to type in, or usually better than the human, I won't say perfect, to help reduce that. Also, the average ambulance across the US is staffed with a paramedic and EMT, and that's about all the help you get on a 911 call. When you're taking care of a super sick patient, all of your focus should be on that clinical care. Typing the exact characters from an insurance ID card into the report is usually about the last thing on your mind. Thankfully, the hospital has an entire registrar department dedicated to do just that. And if you can get that direct connection to their hospital record, it's kind of like a force multiplier for your staffing. Next, crew feedback. Crews get to hone their clinical acumen. So, I kind of liken it to the game show Jeopardy. It'd be the most boring show in the world if you never found out what the correct answer was. And that's kind of what we're asking our crews to do every day, in that we want them to use all of their clinical knowledge and experience to make their best guess of what's going on with this patient. But without that outcome data, we're never going to tell them if they were right or not. So when you have that feedback of, ooh, yes, I was right about this one, or ooh, no, I maybe missed the mark, it on their own can help hone their clinical acumen and make them better providers. You also get crew buy-in and engagement. When they know that their report is going in the hospital record and is going to be read by the physicians and other care team members, there's a little bit more sense of pride that goes into it, and a little bit more, I'd say, desire to be accurate and have a well-rounded report than in the days of the old triplicate forms that you just dropped in a box and nobody ever read again. And then finally, loop closure and mental health. Even when it's a negative outcome, just knowing what happened to that patient that potentially affected you on a call can really help reduce that traumatic stress and help decrease it over time to help improve our providers' mental health, keep them safe and able to keep doing the job. Next, the CQI process. So this is our clinical review process. We can, at least with our PCR vendor, we're able to use these outcome data in CQI categories. For example, if we have one of our CQI rules set up so that if we transport a patient to the hospital and the hospital diagnosed them with a STEMI, but our crew didn't do a STEMI activation, that goes back for our cardiac coordinator to review. So whether or not the STEMI was present on our EKG, they can review all that, but at least it starts that process to help us identify things we might have missed. We also have some automatic alerts set up to medical direction. There's a couple high-risk diagnoses that our medical directors want to know if our patients were diagnosed with, so that they can review the charts that and the care we provided. And then finally, this isn't a primary method of what I would use for infection control, but you can also have alerts and things set up so that if forbid one of your patients that you dropped off at the hospital gets diagnosed with tuberculosis, hospital hopefully would be, or public health would be reaching out to your crew to help with some post-exposure prophylaxis. But as a stopgap measure, you already have an automated connection to the hospital chart. You can have alerts set up for things like these. Protocol development. So we actually use our hospital outcome data as one of several factors that go into determining which calls we respond lights and sirens to. So one of our goals to improve the safety of our community is to decrease lights and sirens usage. So we look at hospital diagnosis as related to our dispatch determinant code, as well as the procedures and medications that were administered by our crews to determine if there really is something time sensitive when that particular dispatch determinant code is sent out, so that we can determine whether or not we need to respond lights and sirens. And also it really lets you tailor protocols to the needs of your community. If thankfully in the Montgomery County area, we have not been hit by the opioid epidemic nearly as hard as many other places in the rest of the US. But we do see some potentially inappropriate Narcan usage from our crews when they go and take trainings from people who were hit. So when we see that our Narcan treatment and the patient wasn't diagnosed with an opioid overdose, we can tailor our protocols to our specific needs of our community and the diseases and clinical conditions that are endemic to our area. And then finally, of course, research. We're working on a research project right now that for stroke, telephone stroke diagnostic tool used in our dispatch center, and relating that to both paramedics doing a stroke activation and hospital final outcome diagnosis of stroke. And then, of course, the NEMSIS research data set. Doing the research and even if you're an agency that can't actively, do the statistics yourself or write the papers and publish them yourself, contributing your data to these national data sets lets you help put the evidence into evidence-based medicine. So whether or not that is a focus or something that your agency does on its own, contributing to the greater data set can still improve that almost in a passive way. So Josh mentioned that we had some issues with our outcome data collection in 2022, and I want to talk through how we improved that. So part of that was our NEMSIS 3.5 transition. I saw that Judy Whitfield was on the call. Back before Texas transitioned to 3.5, I used to get calls from her saying, "Hey, can you pause your uploads? You're updating so many records that it's slowing down our servers." So we did have to take a step back and slow down our data upload speed with those records. But now on the 3.5 system, we're able to update in real time. So we don't have that particular technology barrier anymore, and Judy doesn't have to call me 3 times a week like she used to. So where did we start? Your whole team has to be on board. You have to have the hospital buy-in, and we had to have field crew buy-in. For most of them, until we really explained the reasoning behind it, they thought typing in or scanning the patient wristband at the hospital was just another thing we're asking, and it was silly and didn't have a purpose. So we had to get their buy-in. And then, of course, once you can get a hospital and an EMS agency to completely agree on something, the technology connection is the easy part. So what did we bring to our hospitals for their buy-in? Well, they'll receive the PCR automatically through our automated connections. They don't have to field as many emails from us requesting outcomes. We don't have to field as many emails from them requesting the PCR. We do have regulatory requirements to get that PCR to the hospital, and this fulfills that. And then the big sell to the hospital is for things like their stroke and STEMI registries. They need time of first medical contact or time of first 12-lead EKG. And sending these records to them puts those timestamps that they need for their specialty lines of care already in their EMR. So they don't have to fuss at us to get that information. It's just already in the chart. And that alone was a huge piece of getting that hospital buy-in. Crew buy-in. Like I said, they thought that this was just typing in another number and didn't really matter for anything. Once we were able to show them that, no, when you get this right, you get the outcome data, you get to read what happened to the patient and all of that, that started help bringing in the buy-in. They liked being able to be engaged as part of the larger clinical team. Like I said, the hospital team is going to be reading their documentation. They'll be able to get the hospital documentation and helps bridge that gap between pre-hospital and hospital. Like I said earlier, you can get really reliable insurance information. I know of an agency in Florida that's just told their crews to stop collecting it from the patient because they had such a robust connection with their hospital system that they were getting it automatically. They might not have to wait around and print the PCR at the hospital, depending on your local regulations and how the automated connection is set up. And then again, it just takes one step of regulatory requirement compliance off of their mind. So earlier, I mentioned one of our key foundational values was getting the right data in the right hands at the right time. This is our second one. Evolutionarily, human beings are designed to conserve energy. We always take the shortcut. That's just human nature. I can't tell you I've never met anyone who doesn't get excited when they're able to meet or beat the Google Maps estimated time of arrival from finding a driving shortcut. So one thing that we really try to do is lean into that and not expect our crews to fight human nature and that desire to kind of take the shortcut. We try to make the path of least resistance the way that we actually want them to complete or actually want them to do it. So when we make it the easy way, compliance takes care of itself because it's the easiest possible way to get it done. So with our system, how do we make it easy? We use visibility and validation rules in our PCR system to help guide them to fill out the right number, select the right external outcome number type. I've got a validation rule that's about a mile long of all the things that you can't type in that e-outcome field, like 99999 or all twos or forgot. It was a bad game of whack-a-mole going through all of those every day, and just when I found something that wasn't real, adding it to the list of things they can't type in. And then we also have barcode scanning so that our crews don't have to manually type that number. They just point their iPad camera at the hospital wristband and it goes in their chart automatically. And then finally, the technology connection. So we have 5 major hospital systems in our region that we transport to, and almost all of them connect to our PCR system a different way. So whether that's through a HL7 connection or going through a third-party HDE solution or using No2 for direct messaging or faxing, we really took on the approach that we'll connect to the hospitals however you want us to. Whatever the hospital was willing to share with us, we were willing to figure out a way to connect that back into our system. And then finally, some roadblocks. One of our last hospitals to really get on board with full automated hospital outcome data was hit by a cybersecurity incident a couple of years ago. So since then, that kind of reset all of our progress. We've really been working with their leadership to try and get this approved from a cybersecurity standpoint. I've had other hospitals tell me that it'd be a HIPAA violation for them to share that data back with us, which is absolutely false. One hospital went so far to tell me that when I asked for a fax number of where we could send our records, they said just giving the fax number out would be a HIPAA violation. So sometimes some of the hospital administrators or the charge nurses you talk to may not be able to see the big picture, but that kind of comes back to building those partnerships with your hospitals and trying to find a way to, it may not be the immediate proposed solution, but figuring a way to accomplish the goals that has buy-in from both sides. Funding, like I said, this isn't necessarily a free thing depending on your hospital vendor or your PCR vendor and connections, but we are able to justify to our leadership that, just getting insurance information from 20 patients a year pays for one of those connections if we get reimbursement on those patients that we wouldn't have before. So that really helps us really helped our leadership find buy-in for it. And then, of course, technology limitations. If you've seen one hospital EMR, you've seen one hospital EMR, trying to plug that into an EMS PCR and get that connection established can sometimes be complicated. But once you get the buy-in from both sides, that's really the easy way to figure things out. So that's all I had. I'm happy to take a couple questions, or we can wait till the end and do questions all together. Yeah, thank you guys so much.
Yeah, anyone have any questions for Michael at this time? We'll try to leave time at the end as well, but I think we have a few minutes right here too.
Josh, we're going to pivot a little bit on questions. We're going to save them all to the end and then address kind of how we're going to take those.
Okay, no problem. Thanks, Ben. All right. Well, Michael, thank you for sharing what you've done in your agency and some takeaways and tips there. Let me show you why I chose Jason as our other presenter. This chart here shows the percentage of patient care reports in the national database that have outcomes from the state of Maine. And what's notable about this chart is that it is blank for the last 3 years. And then all of a sudden in 2024, Maine has outcome data from hospitals. We knew this was coming because Maine started working on a statewide integration with the health information exchange within the state that went live in the beginning of 2024. And so I touched base with Jason throughout the year in 2024 and looked in the national EMS database and said, hey, this is great. The outcomes that you're getting, they're making it to the national database. We've got the full end-to-end here that it's actually making it all the way. And so Maine had, in the national database, had about 13% of their records had outcomes. That was across the whole year, but that started at 0 on January 1st. And by the end of December, it was up, I think, close to 40%. So that was an incredible change that happened over the course of just 1 year because of one statewide integration that they did at the state level. And I think that that's something that's very interesting and useful for other states to be looking at. So in Jason's case, this integration is brand new. They've only been getting hospital outcomes for a few months now. And if you are in a situation where you're not yet getting hospital outcomes, then you're going to be in Jason's boat when you first start getting them and you start asking yourself, now what? What do I do with this outcome data? So I wanted to have Jason come on and share with you what they've done and what they're starting to look at early on here with their hospital outcome data. So Jason, go ahead.
Thanks, Josh. That was a fantastic introduction. And Michael, that was a fantastic presentation. Thanks for letting me be a part of that. So my name is Jason Oko. I'm the Data and Preparedness Coordinator for Maine EMS. I've been here with the state of Maine for about 10 years now. I did not start as a data coordinator. I started as a licensing agent here back in 2015. And when I started in 2015, our data guy at the time, his name was John Powers, he was working on getting this done, right? So from 2015 to 2025, this is kind of how far we've come. And just a bit of a roadmap in September of 2023, we had to adopt legislation that would allow us to have access to these records through our HIE, our Health Information Exchange, at the state level. And that legislation actually said, hey, you'll have to also adopt rules that will apply to this. So we did the legislation, formulated that rule and got that all published in 2023. In September, it was finalized, and we actually started testing it. And we received a few records in 2023, but not many. In January of 2024, that is when we transitioned to NEMSIS 3.5. And with the transition to NEMSIS 3.5, we made a focus to begin collecting the required fields that we needed for the outcome data. Those required fields are the MRN of the patient at the receiving facility and the encounter number. We'll talk a little bit more about that in a second. So we started doing that. We were having some great success. There was some agencies, so we added validation to it, and we didn't add any points to the validation. Our vendor allows us to add either more than 1 point or no points, and no points gets you a different color validation. And people saw that it would be a yellow color, and they'd still kind of just pass by it. So in July of 24, we did a system update, and we said, okay, we really like this outcome data, so we want to get more. So we increased the point score on our validation to say, okay, if your patient was a 911 patient and accepted transport to a emergency department or a freestanding emergency department, then you have to get the MRN and the encounter number. And as with any change of validation, obviously that infuriated people. And then now in April, May of 2025, I can look into our system and I can see that we have 38.83% in the last 30 days of the patients that went to a hospital have some semblance of the outcome data as part of their record, which is a really cool number to me. I'm really happy about that number. So just to talk a little bit about how we get it in. We need the medical record number. That's the first piece that we need. And we need the encounter number for that visit. Not every single hospital, what we've learned along the way, calls an encounter number an encounter number. There's out of the 37 hospitals in Maine, we've learned that there is one hospital that calls an encounter number an encounter number. They all call it something weird like a FIN or a CSN or a patient number or an account number, but they don't just call it the encounter number. So to piggyback a little bit off of what Michael was talking about, we're using barcodes to collect that information. This is a Northern Light demo barcode that actually took us maybe 2 years to convince them to add this to their demographic sheet, right? But this barcode parses both the FIN and the MRN directly into the PCR, which was huge, right? Allowing us to gather information. This one is a little bit newer. This one is cool because this is a Maine Health facility, and they're also a large hospital system. They have more than one hospital in the state of Maine. They don't pass out demographic face sheets though. So when you go to the hospital, they put a wristband on the patient. They print a sticker for the crew, but they don't give you a face sheet. So this is a screenshot from their hospital charting system, and they have this at the registration desk so the EMS crew can walk up and they can scan this QR code. And this QR code, believe it or not, has all of this information in it, which is the patient's name, date of birth, their gender, their MRN, their CSN. And it also has their phone, email address, and their home address, which our barcodes cannot parse yet. But if you have the opportunity and you'd like to go to user voice, if you know, and support that user voice idea, we would love that, to add those fields to the barcode parser. But we're excited about this possibility because they are the largest hospital system in the state of Maine with the most beds. So we see that 38 number shooting up significantly now. So when it comes to linking our hospital outcomes with the EMS records, this is, what we're getting back. We're obviously getting back some diagnosis information in the form of an ICD-10 code. which in a lot of instances is super great. In a lot of instances, it doesn't tell the whole story, which is interesting. We are able to get back medication allergies from some of the patients as long as it's part of their record. And as Michael had indicated, insurance information, which is probably one of the singular best pieces of information for EMS agencies that are wishing to be sustainable, is getting that insurance information back. What else are we getting that we think is cool in Maine is the timeline and the disposition, right? So we also have a statewide CAD integration in Maine, and now we're able to see from the time the patient calls 911, or from the time that PSAP date and time, which is highly accurate now, through to EMS arrival, EMS transport, arrival at the hospital, through their acceptance into the hospital, hospital admission, ER admission, to their disposition, whether it be their discharge to home, if they are deceased at the hospital, or if they were admitted to the hospital, or if they went to another facility. We're able to see all of that in that timeline, and to see this. We think this is going to provide us with something cool here in the future. But what is that? What does that time frame look like? And then comparing that to the dispatch reasons, the dispatch determinants too, and also the EMS clinician's primary impression for that type of incident. So, are we having cardiac incidents that are having fast through times, or are we having, lower acuity calls that have longer times? And how exactly does that relate to things that EMS is going to do? And can we develop programs to potentially prevent some of that? So, but we are still, as Josh had indicated, we are still in the learning phase. And so we're collecting this data, and we have a lot of this data, and we're really excited to come up with new innovative ways to apply this data. I took copious notes from Michael's presentation for ways to implement it, and I loved his ideas, and I'm going to blatantly steal them. But we'll have more on this in the future about how we're making use of the data, how we're applying it to evidence-based protocol making decisions, how we can apply it to transport protocols for agencies with specific disease processes, and so on and so forth. But yeah, that is what we're doing in Maine, and I just want to say thank you for having me here. We're excited about this. We're excited to be seen at the national level, and if you have any questions, my email address is right there. I will throw it in the chat too. And thank you.
Well, Jason, thank you for sharing what you've been doing in Maine. I think when you and I were talking a few weeks ago, one thing you mentioned was, when you look at hospital diagnoses, there's a chunk of calls for which the diagnosis is kind of boring and predictable and uninteresting, right? And we talk about having outcome data as like this silver bullet, amazing thing. But we got to temper that message a little bit with, keep in mind, there's a lot of EMS calls that are kind of routine and boring, and the hospital experience is also routine and boring, and nothing much from it, right? And
yes,
and yet there's some that are like highly important. And anyway, I thought that was an interesting thing to be aware of.
We refer to those boring calls as unscheduled primary care. And as an example, if the primary impression is nausea and vomiting, and then you get a diagnosis of nausea and vomiting, it's like, thank you. So, on the lower end of the scale, the less frequent scale, some EMS clinicians are getting those patients where they encounter them, and they're putting their best educated primary impression in, but they're also getting that diagnosis code back from the hospital, and then they're saying, oh, that's what I was right, or like, oh yeah, no, that was bad. We've also seen horrible mismatches, right? So patients with broken legs who they're saying that they have leg pain, right? As opposed to some traumatic incident. And that's probably not the worst mismatch, but it's an example of one. So
And great examples that EMS professionals can learn from to say, oh,
absolutely.
let's check for this.
Yep.
And even on the boring one where they had abdominal pain and the hospital diagnosed them with abdominal pain, it may be reassuring to the EMS crew to know, hey, there wasn't something I missed here. The
Yep.
hospital, that's all they got
Absolutely.
to.
Absolutely.
Yeah.
We did work with one of our critical care agencies in the state of Maine, especially when it came to looking at the dispositions. Thankfully, they have in-house mental health programs for them, because they're dealing with the sickest of the sick. And when you actually took a look at those dispositions for those patients, and there was a lot of patients that were deceased, it was concerning, right? Not from the aspect like they're not doing anything wrong, right? These are the sickest of the sick. These are probably very expected outcomes. But just understanding those ramifications of putting that back on the clinicians, right? Like they're already dealing with the sickest of the sick, which takes a high stress toll already. But knowing that, they can tune this in with their in-house mental health professionals to say, hey, there's a high level of patients that they're seeing that are, uh, deceased after the care. So it's probably something to pay extra special attention to.
And Michael, you had mentioned something along those lines where even when the outcome is bad, that closure is helpful for the crews just to know what happened and to be able to close that. And I was wondering if you have any kind of feedback you've received from them or stories you've heard about how these outcomes have impacted your crews.
Yeah. So I think the biggest impact isn't necessarily just our crews, but our entire 911 response system. So we provide EMS transport for the entire county, but we also work with 12 fire departments who first respond to these incidents within their jurisdiction. Well, 6 of those fire departments are now on the same software platform that we use. So when they transfer a call to us and we transport to the hospital, that outcome data flows back down to our chart and back to the fire department's chart.
Oh, that's
So
great.
not only are our medics getting that benefit, but the fire department and the other responders are able to see the outcome as well. So not only is it helping our medics with their mental health, potentially helping them with their mental health, same with fire departments, but then we've also seen some, the firefighter will look up something in the chart and go, hey, did you see this patient we had the other day had X, Y, and Z wrong with them? I know nothing about that. And it becomes a learning experience for the entire station to discuss that outcome and learn more about that disease process. So it really has kind of helped bridge the gap between hospital, fire, and EMS all in a nice little bow.
Yeah, great. Well, I'd love to open it up to questions from participants, the audience today. I think you should be able to type it in the chat or raise your hand, and we'd be happy to see
Yeah,
what you have to say.
Josh, so the hosts and co-hosts will be able to see questions in the chat if you wouldn't mind just repeating the question as you receive it, and we'll just go from there if we have any issues.
Sounds good. Check and make sure I haven't missed any so far. Nope, just weather reports so far. Any questions for Jason or Michael or myself? Sundown has his hand up.
Again, you're going to have to type in the chat. We're not going to turn off mute.
Okay. Got it. Go ahead and type that in the chat, Sundown. And then Monet said, do we have any updates regarding conversations with the American Hospital Association? I don't. Do either of you have anything on that front?
I don't have anything on that front, Josh. I could tell you one of the things that would be a great topic to discuss with the American Hospital Association is that, and something that I noticed in your slide deck was when it talks about outcome data, the CPC scores and stuff like that. That isn't a standardized data element for hospital documentation. So one of the things that we were ultra optimistic about when we first started this process was our integration with CARES, the cardiac arrest registry to enhance survival, and because one of the outcome fields in there is their CPC score. However, CPC scores, as most people here are probably acutely aware, aren't a timely addition to it, right? So that's like 6 months after discharge, right? Do they have a CPC score? But it's also a narrative-based element. So so whoever the physician is that's documenting that will go into a narrative and say, and enter that into the narrative. Now, if we talk to my colleague here at State of Maine, Darren Davis, who is a SQL wizard, he would probably be able to write some code that would say, look for CPC in there and pull it out and map it to this element. But I don't think it's standardized enough. I would love for NEMSIS and for other organizations, if possible, to facilitate that conversation with American Hospital Association to adopt that as a standardized, drop down score box, right? So they could say the CPC score and the CPC score date assessment is this and what that number is, so that we could actually incorporate that into the outcome data fields appropriately.
Yeah, and that could be part of our work with HL7 and with IHE, integrating the healthcare enterprise, identifying where that data lives in an HL7 version 3 document, clinical continuity of care document, or a fire HL7 fire resource. So yeah, there's some work we could do there. The next question that we've had that's kind of I think dovetailing on this is Maine and Texas receiving, so Maine and Montgomery County Hospital District receiving all of the e-outcome data elements from hospitals. So, there was that list I showed at the beginning of the session today of information that's useful for EMS to receive from hospitals. And not everything on that list that I showed is part of the e-outcome section of the NEMSIS data standard. But the NEMSIS data standard has disposition, it has some arrival and discharge date times, it has medications, procedures, diagnoses, those things. And so anyway, I'll turn Kelly's question over to the two of you to see of the stuff that's in that NEMSIS e-outcome section, how much of that are you getting?
Yeah. So for us, we're primarily getting disposition, diagnosis, and a couple of timestamps. And of course, insurance information. It's not a ton that we're getting back, but just a little bit that we are dramatically helps us. One of the things, Jason, I wholly second your idea or your proposal to get CPC score into a defined data element. But one of the things, and that's normally where I go, but we're trying to actually get the full discharge summary into a data element and that's not so much for a research or for a data analytics purpose, but it's so that there's some sort of narrative thing for our crews to read and actually understand the whole picture of the patient's hospital course rather than just reading some ICD-10 codes.
I also support that. So that's a second. And can everybody in favor please say aye? Yeah, no, that's great. One of the challenges that we're facing too is that we are getting the timestamps, the dispositions, and the patient demographics and the insurance information. And the patient demographics is amazing too, by the way. But the one challenge is, as Mike said, the summary. There is a field for the summary, but we're seeing sometimes there is that sometimes procedures are getting dumped in like a text format into the summary, so we're not seeing those parsed out appropriately in there. The other piece too is that the variability between the way that the hospitals send the data is sometimes vast, right? There's one system in the state of Maine that will release all the timestamps and the dispositions, but they won't release a diagnosis code until they release it for billing. And they're about 2.5 months behind on billing. So people will get to see like, yep, they were admitted to the hospital and they were discharged from the hospital, but they won't get that code until they bill the record. So that's a little frustrating. And then transversely, there's another hospital system that will send an update when the patient uses the commode. So you know, you either wait 2.5 months or your inbox is bombarded with updates, and there's no real in between there. So it's yeah.
Yeah, there's a real role for software to play to digest that data and show what's actually useful to the medics who ran the call, or to the agency administrators who are doing the QA. There's I think a lot of opportunity there for software products to improve that experience. And at least once you have the pipe in place, right? Once the connection is there, then you have these opportunities over time to refine things and to have the discussions with the individual hospitals and say, hey, can we improve this or that? And you've already got the pipe in place, which is a great start. Okay, I'm gonna share one last thing here, and I'll continue to watch for questions that come in. So if anyone else has a question, feel free to type it in the chat.
And while you pull that up, Josh, I'll just say, if anyone's having trouble typing questions in the chat, you're always welcome to open a help desk ticket with the TAC, and we're happy to review those questions as well.
Okay, thanks, Ben. So I want to leave with this little invitation. If you are at an EMS agency and you're getting hospital outcome data, and you're wondering if it's making it into the national EMS database, I'd love for you to contact me. You can email me or call or text me. And what I'll do is I have a data extract from the national database that breaks down by agency what percentage of patients who were transported to a hospital have hospital outcome data on their record. So I can look up your specific agency, and I can look it up for the past 4 years and tell you what the numbers are from the national database. And then we can work together if there's a gap there. If you're getting hospital outcome data, but the national database is showing zeros for your agency, then we can identify where the breakdown is in that data flow and make a fix. And then I could run another extract from the national database a little later and verify that things changed. And we can celebrate that win. That's kind of the low-hanging fruit from the national perspective, is to get those outcomes that are already being received by agencies. So I've got a QR code and a link here, and Lori will put that link into the chat as well. That is a page that we wrote up, again, from the EMS Interoperability Task Force last year, that addresses some of the barriers that have been expressed in regards to, once you have the hospital outcome data, actually getting that outcome data injected into the patient care report data that's being submitted to the state and onto the national database. So there's several barriers that have been identified, and we have guidance for all of those barriers. So while there are opportunities for improvements to be made in the standard itself, as the standard exists today, we can make this happen. And it is in fact feasible, and we've demonstrated it with agencies and even statewide. So feel free to get in touch with me, and I can look up the numbers for your agency, and we can see if we can make a difference there in getting outcome data to the state and national. Now, if you're not integrated with a hospital, with any hospitals at all yet, you might explore this same wiki site that this page is on, where we've really just kind of documented the basics of how you would go about integrating with hospitals. What are your opportunities and choices in terms of network connection options, providers, who you need to partner with, what are the legal and regulatory environment, what data should flow back and forth. All of that is fairly concisely documented on this wiki. All right. Well, that wraps up our presentation. Let me just check the chat again here. Okay, and I don't see any further questions in the chat, and we're right at the top of the hour. So, Chris, anything you have for parting thoughts?
Yeah, a couple of them. Thank you so much. Big virtual round of applause for all our presenters today. I really appreciate all this information and taking the time to come and present today. This was wonderful. This presentation has been recorded and will be up on our YouTube channel and on our website by the end of the week. Again, if you want to be notified about these types of trainings or our V3 calls, the annual meeting, all the other exciting things that NEMSIS is doing, please feel free to make sure to get on board with our mailing list by going to the website and signing up for the mail list, or find us on your favorite social media app. Other than that, I think we're good to go. Thank you so much, everybody, and have a great day.
Thanks, everyone.